for policy change. Finally, we will turn to Lawrence H. Yang. Dr. Yang is professor and chair of the Department of Social and Behavioral Sciences, associate director of the Global Center of Implementation Science at NYU, and founding director of NYU's Global Mental Health and Stigma Program. Dr. Yang has received extensive interdisciplinary training, including clinical psychology, psychiatric epidemiology, and medical anthropology, and is applying his expertise to address the novel topic of migration stigma, where he led a think tank and conference sponsored by the prestigious Ernst Steuben Forum, which has resulted in a recently published book by MIT Press, Migration Stigma. As a reminder for our audience, following individual presentations, we will turn to a moderated group discussion. When we have about 20 minutes left in the program, I will turn to audience questions. Please submit questions using Zoom's Q&A function located in the bottom middle of your screen. Dr. Hill, I will now turn things over to you.
Well, thank you so much. And everybody can see my screen. I really appreciate the opportunity to make the case for a vote for health immigration. As you know, new Americans arrived to the U.S. with a variety of names. In our 10 minutes together, I'll present the case for a vote for new Americans and immigration. First, the U.S. should do their part in care for displaced and vulnerable populations. The UN High Commission for Refugees estimates there are 130 million displaced persons in the world, with over half displaced external to their home country, including 32 million refugees. The vast majority are housed by low and middle income countries. These countries are already stretched and are often the least equipped to care for refugees, unlike high income countries. The US ranks 10th in high income countries in refugees admitted per population size. Displaced persons are not leaving their homeland, friends, family, voluntarily. They're displaced by war, persecution, social unrest, climate change, and a lack of job opportunities. The departure and journey to find a better life is fraught with danger. No one does this unless they have to. All are seeking a safe haven for them and their families. Doing our part includes not causing harm. Many of the federal policies, particularly those of the Trump administration, were egregious and inhumane. The most un-American of these was the policy to separate children from their parents. This policy began in May of 2018 and resulted in the separation of 4,700 children from their parents with no mechanism to reunite them. Trump-appointed Attorney General Jeff Sessions outlined the plan to separate children from families as part of a zero tolerance for so-called illegal entry. And quoting, "In short, no, we do not have any linkages from parents to children, save for a handful," a Health and Human Services official told a top official at Immigration and Customs Enforcement on June 23, 2018. "We have a list of parent alien numbers, but no way to link them to children." The reports from parents describing losing their children with no idea when and how they would see them again is heart-wrenching. Neri Ortega Lima, an immigrant from Guatemala, described the point at which he was separated from his children. "I had no idea where they were taking us," Ortega Lima said. "All the migrants there quickly lined up, and the father only had a few moments to say goodbye to his son, while officials held on to mothers trying to get their toddlers back. I told my son not to be afraid and that everything was going to be okay. I told him to be a good boy." Neris Gonzalez, Salvadoran consular worker who's based in the Ursula Processing Center in South Texas, is quoted as saying, "I'm still shaken by today what I saw, a sea of parents and children being pulled apart, all at the same time in this incredibly chaotic fashion. You know, literally children being pulled on one arm by a border patrol agent, on the other arm by their parent." Soon after inauguration, President Biden set up a task force to assist with reunification. This picture is of a child reunited with his mother after a 3-month separation. Many children spent years apart from their families. As you can see in the light orange, and gray, those are children who have still not been reunited. My second point is that the risks to the U.S. from infectious disease from new Americans are grossly exaggerated. I speak with decades of experience with new Americans, most recently from our program for asylum seeker screening and stabilization, which began in 2018 in partnership with Jewish Family Services and had the addition of Catholic Charities in 2021. These are pictures from our pre-COVID congregation shelter in San Diego. We have received asylum seekers legally in the country after clearance by Homeland Security. The countries of origin are broad, but the most frequent are starred on this map. We have experience in caring for over 500,000 asylum seekers escaping persecution. Arrival by months are shown here for our 3 shelters in San Diego and Imperial County. Each and every one is screened for infectious diseases and urgent illnesses. COVID testing was done on all arrivals after the pandemic began through May 2023 and is now done on anyone with symptoms. By contrast to this level of screening, millions of Americans travel globally each year, and an estimated 80 million in 2022, and they re-enter the country without any screening. The rates of illness we've seen reflect the prevalence of disease generally found in individuals by the age of the guests being screened. Acute minor illnesses such as respiratory illnesses and skin problems such as abrasions, scabies, and minor infections. 81% of the arrivals to our shelter have no complaints. Our 24/7 in-house clinicians care for those with urgent needs, preventing ED referrals, something very welcomed by our community hospitals. So what did we find out about the rates of serious infectious disease? Despite the rhetoric, the rates have been extremely low. While tuberculosis and malaria need to be managed carefully and urgently when they occur, we've only seen a handful of cases in 6 years. We've seen no measles or hepatitis A. By contrast, the politicization of immunization and the war on science has resulted in a drop in vaccines against deadly diseases such as measles, resulting in vaccine outbreaks. As exemplified here, this graph shows outbreaks from 2022 to 2024 with the outline in blue by month. The measles coverage rates vary by state, with the darkest blue the highest and best coverage for those of us who were born fearing polio and having witnessed the deadly post-measles encephalitis and other complications, sterilization for months, and death from childhood meningitis. This situation's baffling. Okay, so what about the selfish reasons to bring new Americans to the U.S., the what's in it for me approach? New Americans fill jobs that keep our economy going. You can see that since the end of the COVID-19 pandemic, there's a large gap between job openings and unemployed workers. Immigration to the U.S. went down from 2016 to 2022, but it's rebounding, but still below average and still contributing to workforce shortages. We've seen the results of workforce shortages, all of us, in big and small ways, from supply chain shortages to our favorite restaurant only being open 4 days a week. Our companies tell us that the inadequate supply of qualified and skilled talent is the second biggest threat to companies' ability to meet revenue or business performance targets. And then there's the phenomenon of the entrepreneurial talents of new Americans, twice as likely to start a new business and benefiting all Americans with jobs and tax revenues. Lastly, our quality of life is enhanced by music, food, language, culture, ideas, and the friendship of our new American community members. Thank you very much.
Thank you so much, Dr. Hill. Now we will turn to Dr. Page.
Hi, everyone. Thank you very much for inviting me, and I'm really honored to be part of this panel. Let me share my slides and introduce myself. So I'm Kathleen, and I am an infectious disease doctor. I'm also from South America, from Uruguay, and so clinically, I end up seeing a lot of patients who speak Spanish and who are immigrant. And so my work and my research often is informed by the patients that I take care of. So let me see if I can move forward. Yeah. So let me start. I'm going to start actually with a patient that I saw in clinic. This was probably like 10 years ago. And I got a call from the health department because they had tested a pregnant woman from Guatemala in an outreach activity and found that she had syphilis. And the health department was quite concerned about the possibility that her child would have congenital syphilis if she wasn't treated. But unfortunately, the attempts that they were making to contact her had been unsuccessful. So I called her and spoke to her in Spanish, and she actually answered and was very willing to come to my clinic to see me. So we arranged for her to come in. I gave her directions. And then on the day of the clinic that morning, I actually called her to remind her and to make sure that she knew where to go. And she actually said to me that she was only 2 blocks away and would soon come to my clinic. I got busy during the clinic, and at the end of the day, I realized that she had not come. So I called her back, and she said to me, I actually got there, but there was a security guard at the entrance of the hospital, and I don't have any papers, so I felt like I couldn't go in, and so I left. And I think that spoke to so many issues that often impact immigrants, and especially those without documentation status, for whom the fear of deportation is really front and center. This involves not only deportation, but often family separation, and how that colors so many things, that how they interact in day-to-day life. So we and many others have talked about the chilling effect, which is how unfavorable immigration policy or rhetoric or just talking badly about immigrants can impact health through a number of pathways. So in this case, this patient had an increased risk or perceived risk of deportation. Really, there was no risk to her that she would be deported by coming to the hospital, but she didn't know that. And in her case, that resulted in decreased healthcare utilization. And of course, that can have health impact. In this case, could have had a health impact for her baby. But there's also the very direct impact. Sorry, I'm having, sorry. The direct impact that unfavorable immigration policies rhetoric have on people's health, on their mental health, on the stigmatization that I think you probably will hear about more later. So when I think about immigration policy and health, I think about policies that are intended to really dissuade either migration or really make life very difficult for migrants who are here. And those include things like deportations, especially if they're arbitrary, and everyone who's a migrant who maybe doesn't have a documented status or who looks like someone who, or maybe is targeted because they're profiled as someone who may not have documentation, could be detained or deported. The criminalization of immigrants, family separation, public charge rules, exclusion from the safety net, all those are things that are cooling. And then there's some things that, while they're not, of course, the most warming policy would be a pathway to citizenship, but short of that, there are things that really do make a difference, right? So where you live, and if that city or place that you live in has made it friendly for immigrants, if you're able to get a driver's license, DACA is a type of more warming policies. And so do these policies have impact on health? And the answer is yes. So this is one of my favorite studies that was then conducted by a Stanford group. And they looked at the impact of babies, on the children of mothers who were immigrant, of whether the mothers were eligible for DACA or not during their pregnancy. And they looked in the long term to the outcomes, their health outcomes, and particularly anxiety. And what they found is that those moms who were eligible for DACA, their kids had a 50% reduction in a number of behavioral health outcomes. On contrast, this is data from our hospital during the last, when Trump ran for office the first time, we saw a decline in healthcare utilization among Medicaid ineligible people that come to our hospital through a charity care program. And basically, this is mostly immigrants of low income. So then in this context, we had the COVID-19 pandemic. And I think for many of us who work in this area, this really highlighted things that we all knew were happening before, but the COVID-19 pandemic unfortunately really shone a huge bright light on these inequities and the impact, again, of these policies on health. This is, again, data from our health system, looking at the first wave of the pandemic and the positivity rate of COVID among Latinos, who you can see up here, up to 50%, and this went for a lot longer. And then you can see disparities, certainly, like African Americans at the time had almost twice as high positivity rate as whites, but really it was the Latinos that really stood out. And I remember very clearly the first week in April when I got pages from all over the hospital telling me, because they knew I worked with this community, that 50% of our ICU beds were being occupied by Spanish speakers. And this was unprecedented because of access to care in our health system. We don't often see that many immigrants at all in our communities. Just to put context, about 5% of the Baltimore population is immigrant. This is an example of one of the emails I got, but I think this email highlights so many of the things that come together, social determinants that come together with immigration status, and particularly undocumented immigration status. So this ICU attending said to me, I'm emailing you because he was talking about the immigrants that he was seeing in his ICU. They all seem to live in large households. They continue to go to work. They have many people who are sick in their families. They all live together. They don't have a PCP. There's also massive hesitancies towards letting anyone know. And from stigma to legal concerns, it is clear that unless someone really needs to be in the hospital, they are not seeking attention. And I think this just really encapsulated so many of the things that we saw and that drove this really inordinate impact of COVID-19 in this population. Now, the CDC, if you looked at the graphs on prevalence and hospitalization and even deaths during this period, you would see that Latinos really were heavily impacted. But of course, most Latinos in this country are US born and they're not immigrant. And we don't capture data on immigration status. But if you read between the lines, and these are some articles from the time, from the newsprint, you could recognize that among the Latino community in the US, the most vulnerable really were those who were undocumented, who had to continue to go to work, who had no social support, who were not getting the stimulus check, and who did not know that they could get care under the CARE Act. So during this period, there was, I think, a huge movement, in part because of what was happening with COVID. Also, there was racial reckoning because of George Floyd and other things, but really a recognition that there were these huge disparities that had always been there, but had been highlighted. And there were things that happened, like the CARES Act, that really helped care for people, regardless of immigration status, and NIH initiatives that also led to more interest in this type of work. And I do want to highlight, these are people from Baltimore, but I think this happened throughout the country, the essential role that community organizations and the Latino community itself, and the immigrant community in particular, played in trying to respond to this crisis. But unfortunately, things have changed. And while this was very galvanizing, and we all hope that this would change forever, and there would be really investment and interest in these issues, we all know that immigration, unfortunately, has become a really hot potato politically and everything. And I think one of the influences for Trump, the fans' ticket, is that everyone has moved to the right. And this has become a very difficult topic for everyone. So this is just briefly some data that I pulled out from the Pew Research Institute, looking at attitudes between Trump supporters and Harris supporters on issues of immigration. And I want to highlight this one. 88 in this survey, 88% of respondents who support Trump are in agreement with mass deportations. And Dr. Hill just showed what that could look like. Mass deportations is something that this country has really not seen forever or in a long time, and they're quite disruptive, not only to immigrants and to their human rights, but also to their families. But I would also argue that it's really concerning that almost 30% of Harris supporters feel that that's also a good idea. The other questions that were asked were about the impact, are immigrants making things worse? And again, a pretty significant group of most Trump supporters think, for example, that immigrants are draining public resources, but almost 50% of Harris supporters do too. And I think that just speaks to the language that has been used throughout the last few years. Speaking of access to care, I was very grateful that the CARE Act gave access to care to all for COVID, but right now the Affordable Care Act is at risk during this election, and these are this is not the Affordable Care Act, these are state policies that expand access to care regardless of immigration status, but you can see that it's a minority, and the issues that drove some of the impact that we saw of COVID-19 on immigrant populations are still there. Most immigrants, especially those who are undocumented, don't have regular access to healthcare and insurance. And then finally, I just want to clear up some misconceptions about the drain, so-called drain of immigrants on our economy or on public services. So it's estimated that in 2022, undocumented immigrants contribute about $100 billion in taxes because they do pay taxes through various means, whether it's sales tax, state tax, or through an ITIN number or employment. Much of these taxes, about 35% of these taxes, go to social security programs, Social Security, Medicare, and things that they will never benefit from. So in effect, they're subsidizing many of our programs that we all rely on. And then finally, to make a point that I think Dr. Hill also made, to remind people that migration is really a global phenomenon with conflict, climate change, poverty. This is only going to increase. But that the majority, this is data on refugees, the majority of refugees move to neighboring countries, most of whom are low and middle income countries. So in comparison to the world, the US, while yes, I want to acknowledge we have received more immigrants maybe in the last year, it's not unprecedented. It's not so big compared to our size and our GDP. And this just shows the same data that 43% of migrants, this is not just refugees, but also economic migrants, are going to low and middle income countries. And so with that, I will stop. Thank you very much.
Thank you so much for that incredible presentation, Dr. Page. Up next is Dr. Rodriguez.
Do you all see my screen? Just to confirm, Sarah, thank you. Well, along with Dr. Hill, Dr. Page, and Dr. Yang, thank you so much for the invitation. My name is Darlene Xiomara Rodriguez, and I am a macro-level social worker who is the founding member and co-director of the Georgia Immigration Research Network, which is an entity that brings practitioners, policymakers, professors, and lay people together to be able to do action research that transforms lives here throughout the state of Georgia. I'm also affiliated with Kennesaw State University's Wellstar College, and in line with what my colleagues have shared from a public health and medical perspective, I hope that my contribution will add some value to how this affects community well-being. So as far as the phrase, all politics is local, you may have very much heard this in US politics. However, despite the US federal government holding primary authority over immigration policy, it is important to know that states and localities also play a significant role in shaping how these policies are implemented on the ground. This is known as immigration federalism, and the dynamic relationship that exists between federal, state, and local governments in the regulation and enforcement of immigration laws. Historically, the federal government has been responsible for setting immigration laws, such as determining who can enter the country and under what conditions. However, several state and local governments have had leeway when it comes to enacting laws that affect the daily lives of migrants, such as issuing business licenses, providing health and welfare services, as well as regulating housing. The interplay can lead to a variety of approaches across different states. For example, some states have passed restrictive laws aimed at making it more difficult for undocumented immigrants to live and work, while others have enacted more inclusive policies to integrate high-skilled immigrants into their communities. This reality has significant implications on how state and local immigrant policies impact health. Therefore, immigration policy, like other forms of public policy, has direct effects on many of the institutions where immigrants live, work, and strive to thrive. These institutions shape individuals' access to opportunities that promote health, such as educational advancement or exposure to circumstances that may harm their health, such as being constrained to segmented labor markets where immigrants with low educational levels are limited to occupations with harsh working conditions, low pay, and minimal job security, often known as the 3Ds. Dirty jobs, which are jobs that involve tasks that are physical, unclean, and unpleasant, such as waste management, sanitation services, and factory work. Dangerous. These jobs pose significant risk to workers' health and safety, such as construction, mining, and agricultural work, which are prone to accidents and injuries. And then third, demeaning. These jobs are often low status and can involve repetitive, monotonous tasks that offer little respect or recognition, such as domestic work, child caregiving, as well as service industry roles. Collectively, these 3D jobs perpetuate immigrant vulnerability and the likelihood of exploitation, often resulting in the fourth D, death. Consequently, there are social determinants of health that play out at the state and level policy decisions, and how immigrant status, regardless of it being entry without inspection to legal permanent resident and even naturalized U.S. citizens, intersects with the embedded political system and the policy arena. Those institutions and systems are influenced by the social, political, and economic forces and their corresponding public, private, and nonprofit sector entities. Each of these shape the lives of individuals and their households, often those with mixed immigrant status. And this includes the impact on distance for employment, school, and options that come with additional anchor institutions, and ultimately how this intersects with the criminal justice and immigration detention system. These are all predicated on the individual status of the individual, and thus impacts the social, psychological, physical, and mental well-being of the newcomer within the United States, many of whom have had to navigate the social and economic institutions of a new country with little guidance, little to no command of the English language, and a lack of understanding of the rules and responsibilities set forth by common law or community norms. Collectively, this creates general stress and anxiety and influences decisions about health behaviors and public use service, much like was described by Dr. Hill and Dr. Page. While immigrant policies tend to focus on specific non-citizen groups, especially those who have been here for less than 5 years, there is evidence that the exclusion and the extension of rights of one non-citizen group has an impact on other non-citizen individuals. These include asylees, refugees, DACA, TPS, and visa holders. Current immigrant policies are proposed within a larger, broader national context of anti-immigrant climates, thus creating discrimination against non-citizens in general. Therefore, one needs to be mindful that beyond federal elections, which are highly important, one needs to also think about how this plays out in local and state arenas that perpetuate anti or pro-immigrant behaviors. For all these impact health services, health status, and one's quality of life, because it is largely determined by one's local environs. Based on the research completed by my research team, we have come to differentiate anti and pro-immigrant communities by this receptivity climate in the local community. As was discussed by Dr. Page, this idea of cool and receptive climates versus warm receptive climates is quite important. In a cool receptive climate characterized with less supportive policies, limited resources, and a general lack of community support for immigrants, both with community-based organizations and public institutions, the environment can make it more challenging for immigrants to settle and integrate successfully. For example, in an anti-immigrant community, one can see how the push and pull factors of migration can yield to increased levels of fight, flight, freeze, or fawning by individuals. And this persistent fear and negative social interactions with authority figures and public institutions result in immigrants having poor health outcomes and avoiding preventative care, which yields to increased emergency or crisis health management use, and only compromises not only their lives, but puts a burden on the healthcare system and associated social service providers. However, if one is in a warm, receptive climate marked by supportive resources and services that are in abundance, and a community of networks that welcome and assist immigrants, such that as through the GERN organization that we've developed, environments foster better integration and overall well-being for the immigrant community. As an example of a warmer climate for reception and inclusion, we found that immigrant communities actually felt safer based on our research during the COVID-19 pandemic. And although that may seem quite odd, it is because if they were in a receptive community, they were able to receive emergency Medicaid and COVID-19 assistance that may not have been available to them prior. And because of them were essential workers due to the 3Ds described earlier, they had job security, despite the fact that they put their own lives at great peril. Because of the fact that they were in healthcare, grocery, pharmacy, manufacturing, and agricultural industries, they were needed by the American public. And so despite the fact that they put themselves at great harm, they were able to benefit from these social support services. Now, as far as this effort, one is needed to understand that immigrants as part of this population are often considered discardable. However, immigrants within the healthcare sector are indispensable. Immigrants account for 70% of the workers in the healthcare occupational fields. Most immigrants are employed by the US healthcare system, come from the Caribbean and Latin America, with Asia being the highest at 42%. Immigrants make up 24% of direct care workers, such as nursing, psychiatric, and home health aides. Immigrants also make up 28% of highly skilled professionals, such as physicians and surgeons. Therefore, know that receptivity climates impacts the full spectrum of immigration status, experience, economies, education, knowledge, skills, and abilities. And the ability to create a less onerous path for revalidating and recertifying immigrants with health, medical, and human services skills from their native countries will reduce the significant brain waste that is currently taking place. An issue that has significant public health ramifications, especially knowing that there is a shortage within the US system that cannot sustain. Therefore, framing immigration status as a social determinant of health underscores challenges many immigrants and their families face accessing health services. Laws and policies impact health outcomes, and for immigrants, it also impacts the regulation process of health insurance and health care, as well as influencing the overall quality of life and their decisions for health-seeking behaviors. Such laws and policies also contribute to structural racism by excluding certain racialized groups like undocumented immigrants and others from accessing healthcare and other services, which leads to disparities in health outcomes, much like was described by Dr. Page by her Guatemalan patient. Tia Taylor Williams in 2020, the director of the American Public Health Association Center for Public Health Policy, stated that racism, not race, is the cause of such disparities, emphasizing that the disproportionate burden of COVID-19 among communities of color and other marginalized groups is due to inequitable policies and treatment at the individual, community, and systems level. Those inequitable policies and treatment outcomes predated the COVID-19 pandemic, and yet they persist during the endemic phase and are regrettably remaining with us now. However, I do bring some hope of some positive strides. The map to the left that you see is from the Migration Policy Institute and identifies cities and states throughout the US that had the greatest number of migrants residing within them between 2018 and 2022. The US states that have the most immigrants are California, Texas, Florida, New York, and New Jersey. In terms of cities, the New York metropolitan statistical area was home to more than 5.9 million immigrants, followed by the greater Los Angeles area with 4.2 million and the Miami MSA with 2.5 million. This is something you are likely quite familiar with. I, however, want to superimpose that map with the one on the right. As the co-director of the Georgia Immigration Research Network, one of the community partners that we have worked with is Welcoming America, which has its national headquarters in Decatur, Georgia. As a national nonprofit, it has the conviction of trying to make communities better by helping with decisions that are made to make meaningful lives for all residents, regardless of their backgrounds. The Welcoming Network is composed of around 300 nonprofits and local governments working to build more warmer, receptive climates, inclusive and welcoming communities throughout the country. The points that you see on this map are the 25 certified welcoming city, county governments and communities that have gone through a formal process to be designated as such. This is due to the creation, implementation, and assessment of policies and programs reflecting their values and commitment for immigrant inclusion. You will see that although there are several welcoming communities that reflect the map to the left, there are others with low levels of comparative migration flows that are also considered welcoming cities. The resulting climate shapes the racialization of people of color broadly, and immigrants in particular, and creates social and economic security and insecurity, promotes immigrant certainty or uncertainty about their daily lives, and shapes their perspectives about the trustworthiness of public institutions. Therefore, local policies influence key institutions which shape the ideological context and ultimately public health. I therefore encourage you, as those of you who are attending this session, to check out Welcoming America and see if an organization, a city, a county is part of the Welcoming Network, and see if you are able to find ways in which your public health affiliated agency can be a part of this network as well. If so, you'll have the potential to transform the lives of immigrant communities at the local level, which has the potential to influence regional and national policymaking. In fact, within the Atlanta metropolitan statistical area, I was part of a steering committee of 60 individuals who worked for several years to devise, implement, and assess phase 1 of a national pilot program for regional immigrant integration called the One Region, which utilized these 7 standards to the left. This was a partnership between the Atlanta Regional Commission, the Community Foundation of Greater Atlanta, and Welcoming America. Now we are in phase 2, as we build on that success and the lessons learned post-COVID-19 to make Atlanta and the MSA a place of more welcoming. And in the face of state and national realities that make the South an increasingly cold, receptive climate for immigrants and historically for Indigenous, Black, and other marginalized communities, it is our hope that Southern warmth and hospitality will prevail. As an outgrowth of this work, we saw that great things were happening throughout the United States, but much of the story was not being shared, especially in the last 25 years. Consequently, members of GERN, the Georgia Immigration Research Network, sought to contextualize the ongoing changes to new destinations, and in so doing, identify challenges, opportunities, and best practices emerging from different metropolitan regional contexts. This project reflects the value of community-based participatory and community-engaged research, where collaborators are co-equals in a generation of dissemination of knowledge. There are 14 cities that are identified in this text, and we would encourage you to use this as a resource for practitioners, researchers, and students. Additionally, I'd like to draw your attention to these 4 journals: the Health Promotion Practice Journal, the Journal of Urban Affairs, the Journal of Migration and Health, and the Journal of Race, Ethnicity, and the City, to learn about projects that have been produced through the Georgia Immigration Research Network to see if community well-being at the macro level would be of interest to all of you. I'd like to say thank you, muchas gracias, for inviting me to be a part of this. And if you'd like to connect further, feel free to reach out to me on LinkedIn. Thank you.
Thank you so much, Dr. Rodriguez, for that insightful presentation. And I certainly will be reaching out. I want to pass this on to Dr. Yang as our final presenter.
Great, Sarah, can you see my screen? Excellent. Hello, everybody. First of all, I want to thank Dean Galea and Boston University for the opportunity to speak at this distinguished panel, and also my co-panelists who I've learned a lot from. So the title of my talk today is Migration Stigma, the Human Cost of Politicizing Immigration. And just a little bit of introduction, I have been, much of my work has focused around stigma of varying health conditions, and but now I am actually taking this work and moving it into the phenomenon of migration and immigration. So quite recently, as some more context, I had the opportunity to be supported by the Ernst Strugman Forum. Just a little bit about this forum. Their hallmark is to bring together fields of study that have not been in formal dialogue with one another prior. So, so in this case, we brought together a set of stigma researchers and migration researchers and brought them together in order to, again, come into dialogue with one another in order to really illuminate new knowledge, generate new knowledge at the intersections of these fields. I want to note, of course, that I co-led this initiative with my collaborators, Bruce Link at UC Riverside, Maureen Egger, currently at Stanford, who are, tremendous. I couldn't have done it certainly without them. They have been tremendous contributors to this entire effort. So in 2022, we convened these about 30 scholars to examine this topic to address gaps in knowledge, and this has resulted in a recently published edited book from MIT Press. And the result of this work is what I'm going to be describing to you all is this we believe to be this new concept of migration stigma. And just a little bit more about, again, the framing of this. So in terms of stigma research, there's been a lot known that's around stigma of different health conditions. That's been actually the primary focus of the stigma field, but less so around applying the processes of stigma in relation to immigration. Conversely, while migration researchers have really studied a great deal around prejudice, so negative attitudes towards migrants and immigrants, immigrants and their descendants are actually subjected to the full array of the stigma process, and which I'll be describing to you in just a little bit. So what we discovered through this convening was this, and coined, was this concept of migration stigma. And what we saw was this opportunity actually to take Bruce Link and Joe Phelan's classic conceptualization of stigma in 2001 and apply it to the phenomenon of immigration. So we define it as the co-occurrence of labeling, and I'll return to this concept specifically in just a little bit, stereotyping, separation, status loss, and discrimination in the context of power differentials in relation to a racial or ethnic group with a history of an international migration. So that's a lot to take in. I'm going to break this down further in the next slide for you all. But one thing
Dr. Yang,
yes,
just want to interject. We can see your notes, so I'm happy to share slides from the view side, just so that your presenter notes are showing.
Go ahead, no problem. Why don't you go ahead? Take over from slide 4. I apologize for that. I thought we had fixed this earlier. Thank you so much. Fantastic. So, so what I want to note here is essentially that again, the migration field is focused more narrowly on this concept of prejudice. But here, what we have been able to do is really fully elucidate the mechanisms of stigma by which politicization of immigration takes place, and then also, as I'll describe in just a little bit, how this is then linked to mental health of immigrants. Next slide, please. So in this figure, you could see, and again, I'll use I'll illustrate this with the phenomenon of immigration. So the process of stigma starts with labeling or being identified as a migrant or an immigrant. So here, the immigrant or individual is identified again as, of being of this status. To note here, you don't actually have to be a migrant or an immigrant to actually be labeled as such, and this plays a important part of the story a little bit later on. This can then elicit the negative stereotypes. So this unfortunate stereotype of being undeserving, for instance, in terms of being a migrant or immigrant. Separation, which is othering, so basically, us versus them, and then status loss and discrimination. So status loss in its most severe form can occur as dehumanization, and discrimination can take place both at the individual level, so social exclusion, and then at the structural level, so lack of access to employment and healthcare, as we've heard from our previous speakers. And when these phenomena take place in the context of a power differential, as many migrant and immigrant groups experience, then we see this as leading to stigma. Next slide, please. So we then had the opportunity to further advance some of these arguments in a recent publication in the Journal of the American Medical Association. This was just published a couple months ago. And here we further argued that prior studies have really focused on how politicizing immigration benefits political parties and candidates, and also explaining native-born attitudes. But these studies, again, with some notable exceptions, do not typically go on to investigate the impact of bias on immigrants' health and well-being. And so this concept of migration stigma, we believe, helps to describe how a stigma process is initiated that ties together phenomena that can be typically viewed separately, and also has impacts upon health and mental health. Next slide, please. So a very powerful, I guess another potential extension of this concept is how the stigmatization of immigration can potentially extend to the health of immigrant families and also their descendants, so people of second generation and potentially further on. And we are actually testing this idea, and I'll describe this in a second, around how migration stigma could potentially contribute to health inequities across racial and ethnic groups who aren't necessarily immigrants themselves. So the key idea here is that politicization, this rampant politicization that is occurring today, has health consequences not only for immigrants, but also anyone whose race or ethnicity makes them susceptible to being identified or being labeled, again, as a migrant. And Mere awareness of the negative political environment can elicit adverse psychological effects. And we heard this from our prior speakers. Today, I just pulled this from a New York Times article just from today. So this is from a Latino American respondent in Nevada, and he says of former President Trump's prior quotes. So calling us murderers, rapists, and drug dealers, it just hurts me as a Latino. It hurts me as just a person. And so obviously these, this intense negative politicization can then impact people's mental health. Next slide, please. Oh, can you bring up the whole slide? Thank you very much. Perfect. So we are now in the midst of developing a new measure of migration stigma. And so we are advancing a nationally based survey, rolling it onto the field as we speak, of over 2,000 immigrant and non-immigrant individuals in advance of the US presidential election. And one of the core innovations of this study is that we're utilizing this framing. You can see it in the top box here, that most people in America believe that. And so the respondent doesn't actually ask the question from their perspective. They ask about what other, most people in America believe. And then there's a negative stereotype, a typical one here, unfortunately, being that immigrants increase crime rates. And so this measure obviously can act as a measure, a barometer of anti-immigrant attitudes. However, to test the prior idea that I had, introduced in the prior slide, if we go down the left arrow, we see that among immigrants and some ethnic minorities, we see that that the endorsement of these attitudes that most people in America believe, these stereotypes, could then activate self-relevant, basically be self-relevant to immigrants and some ethnic minorities. And so endorsement of these negative attitudes could then lead to a negative impact on health and mental health. If we go down the right side, we see here, let's say if you're a native born or ethnic majority respondent, and these beliefs are not self-relevant, right? You're aware of them. Okay, there are high negative attitudes towards immigrants, but I'm not of that group, I'm not associated with that group. We would see this as having no relationship to health and mental health. So the critical piece being here again that these negative politicization that's occurring could spill beyond people who are actually immigrants, but to anybody who could be potentially identified as an immigrant. Next slide, please. So just a little bit here, the prior speakers talked about this, quite eloquently. I'm going to focus on the purple boxes here. So essentially, aversive policies towards immigrants can lead to poor mental health outcomes. We saw some great examples of that in the prior speakers' talks. Awareness of the political environment, perceived threat of policy elicit negative health outcomes. And again, this was, I think all of us have spoken about this. And then lastly, that beneficial policies towards immigrants could lead to improved mental health outcomes. And so these are the levers by which we could hopefully try to mitigate, these damaging circumstances to migrants and immigrants. In the orange boxes, you can see here some supporting studies pulled from other immigration studies or LGBTQ+ studies that support these points. Next slide, please. So just to wrap things up, what I've spoken about today, number one, is I hope to introduce this new concept of migration stigma. We believe that it can bring new analytic power via a multi-level, multi-component stigma framework to the phenomenon of migration, and that it will also allow an explicit linkage, between migration stigma and mental health. Secondly, that this phenomenon of migration stigma could extend to anyone whose race or ethnicity makes them susceptible to being identified as or labeled, quote unquote, from the theory, a migrant. And then ultimately, we hope that this concept can be used to propose social, economic, and policy solutions to address the harmful consequences of migration stigma. So thanks you so much for your attention today, and I look forward to, I'll turn it back over to you, Sarah.
Thank you, Dr. Yang, and thank you to all of our speakers for their presentations. We now are going to move into our moderated discussion with our speakers. As a reminder, we're going to turn to audience questions when there's about 20 minutes left in the program. So please submit your questions using Zoom's Q&A function at the bottom of the screen. So as a longtime immigration reporter, this has been incredibly informative, and true to form, I definitely have a couple of questions, and I ask any or all of the panelists to weigh in if you're comfortable doing so. So first off, this may be more related to Dr. Hill and Dr. Rodriguez's presentations, but if anyone wants to weigh in, what state and federal reforms have been introduced to expand public health benefits for migrants and immigrants who have been here? And how will those hold up under either new administration?
I can take a stab at the first part of that. And so I'm clearly in California. California has expanded Medicaid to include almost everybody in the state who's a resident, irrespective of legal status. And that this has been incredibly effective. I'm actually here in a FQHC, a federally qualified health center, where I've been in practice for 45 years. And so I remember past times when access was limited, and if people could come here and they needed referral to specialists, we had no way to do that. And in California, that's all changed. So I'll stop there and let my colleagues respond.
Thank you so much, Dr. Hill. In addition, I would say Washington provides state-funded health coverage for low-income migrants, including undocumented adults. Oregon, which I just came from last week from another conference, similar to California and Washington, they offer comprehensive health coverage for low-income residents, regardless of immigration status. Colorado also extends healthcare coverage to low-income residents, including undocumented individuals. And then when you think about like children and pregnant women or children and families, since again, we come from possibly a US born child and an undocumented or immigrant variety of status as parents. And that's partly my story. My mother came here before giving birth, so I would be born here in the United States. And then we returned back to Venezuela. So being biracial, bicultural, bilingual, I've had to deal with this very issue myself where I could get help, but my mother could not. And so when you think about New York, Illinois, Massachusetts, and New Jersey, they all have either a state-funded program for health insurance for income-eligible children and pregnant women, regardless of immigration status, and seek to provide health equitable options to be able to improve the generalized public health and well-being of their residents and citizenry. And then separate from that, Minnesota started offering healthcare coverage for low-income residents for immigration statuses beginning in 2025. And so that's a big deal come January 1st, 2025.
Right. So the next question comes from Dr. Hill, actually, and it sort of intersects a little bit with a question that I have. So here in Massachusetts, there have been a growing number of migrants seeking humanitarian relief over the past year and a half. And as we put people into the shelter system as they qualify, one of the things that comes up along with ESOL classes and work authorization is healthcare, especially since some individuals may be more high needs and have more medical issues than others. How are states managing and providing medical services to new arrivals? And also, how is this sort of part of the debate over funding for those medical programs? And how do you convince people that this is beneficial to your local society?
I can start the dialogue on this, but I think my colleagues also have a lot to say. There's two types of shelters for asylum seekers, for example. So the types of shelters that I'm directly involved with are those shelters who are receiving people from the border directly, from Customs and Border Protection or Border Patrol. And we've been able, partially because we're in California, to be able to provide the kind of services that I described, where we're screening all of our guests and we're providing 24/7 medical coverage. The second type of shelter are those who are in cities who are receiving their, asylum seekers as secondary, when the either because the asylum seekers have chosen to go to that city, or because in some cases they're being sent from certain states involuntarily to those cities. And I think that has been the harder problem, because we did a national survey fairly recently where we surveyed asylum seeker shelters across the country. Only 13 of the shelters fully completed the survey, but only 30% had any kind of medical services. So I think that you bring up a very important point.
I guess maybe I can add a little bit to that, since I don't live in California, and I'm now very jealous, because we don't, here in Maryland, we have also received a large number of immigrants recently. We don't have comprehensive care. We did pass the Healthy Baby Act, so now pregnant women will get care regardless of documentation status, but that has not been expanded to other groups. So, it's really a fragmented and patchwork type of health system that people have to navigate. This, I acknowledge, is also the case for many Americans, but it becomes even more complicated if you don't have health insurance, if you don't speak the language, if you're not familiar with the health system. So there really, I would say there's not a strategy or a coordinated effort. As Dr. Hill mentioned, many immigrants come quite healthy. And so I think the risk and the cost of providing care for immigrants has been overblown. Despite the fact that we have to acknowledge that so many of them come from traumatic situations, and probably there's very underdiagnosed or undertreated mental health needs for sure. But for those who do have health needs, I think the patchy thing that ends up happening, and certainly a lot of people fall through the cracks, and we end up seeing them very late when they come in very sick to the emergency room, is a combination of federally qualified health centers, which are at capacity and don't have enough access and don't have enough language access, et cetera. Community organizations that really try to create welcoming spaces, but they're not everywhere. And especially, for example, in Maryland, in rural areas, that can be really much more complicated than if you come to a city like Baltimore. And then in my own hospital, like many all nonprofit hospitals, we have to provide charity care. We are lucky at Hopkins, and I help direct this, that we have established a clear pathway for people to get charity care at Hopkins, which includes bilingual navigators and really outreach to communities, so people can get care before they're really sick. But I would say that type of model is the exception. And for the most part, many immigrants get no health care unless they get so sick that they end up in the hospital. And that's, of course, much more costly than preventive care.
Okay. And finally, one question, and I'd really like to hear from Dr. Yang about this. What is being done to educate the public about the inaccuracies related to migrants and health, especially ahead of the election, now that immigration has become such a flashpoint?
Oh, that's a really great question, Sarah. And I think unfortunately the answer is that I don't think we're doing enough. A lot of times, to really, one of the biggest ways, sort of the most tried and true way of of countering stigma is actually to try to humanize the story, right, through people sharing their narratives. And so I think that's why I believe, in its most effective forms, when the suffering that the immigrants go through, in terms of separation from families, that's been a predominant framing, right? People can relate with that, whether you're an immigrant or not. People love their families. People can now just imagine the horror of being separated from one's family. And so it's these types of framings that are actually the have been shown to be, among the more effective ones in terms of reducing stigma towards migrant and immigrant groups. I'm not sure, actually, it's a good question in terms of how that's been explicitly turned towards health. And I think that that's maybe an area that we on the panel could really think about now and for the future. Yeah, I'll leave it at that.
So there's been a debate over many administrations about how the Executive Office of Health and Human Services works with DHS in caring for unaccompanied minors. And these are the most vulnerable of all immigrants. These are children who are coming here alone. Have there been any improvements under the Biden administration to the situation and any progress on healthcare being more trauma informed for these children? For anyone who wants to respond.
Sorry, I'm not involved. I think I broadly heard that's the case, but I'm not involved. But maybe some of the other panelists have more direct experience.
I could just speak to an area of trauma-informed care that you mentioned, Ms. Betancourt, is that the administration has tried to emphasize more trauma-informed care during this administration than comparatively in the past, recognizing the psychological needs of minors. And one of the things that I found was that children having access to mental health services has been allocated to be able to help deal with the post-traumatic events after reunification. But to Dr. Hill's point, so many of them are yet to be reunified that those issues are going to permeate not only for the individuals, but for generations to come. And so the psychological trauma and how that intersects with public health, I think we're really not going to see the full manifestation of that until 10, 20 years from now, when these young people become adults and they find themselves in a situation of heightened untrustworthiness of government and how that will change American society as a whole.
Okay, well, I'd like to transition to some of the questions in our Q&A. First, we have a thank you to Dr. Hill, and one audience member is asking if you could please talk about the process you use / implement to screen / diagnose for TB, and what was the LTBI rate?
Well, thank you for the question. I think I just need to step back for a minute and talk a little bit broadly about the kinds of screening that we've been lucky enough to be able to do just north of the border. We receive guests who are arriving, as I said, from DHS, and our guests are housed and sheltered by our humanitarian partners, Jewish Family Services and Catholic Charities. My team at UCSD provides screening. We provide symptom screening with protocols that we vetted with our ID colleagues, and we're public health docs ourselves, but we also worked with our public health department. Our guests, as we fondly call our clients, are sometimes spend as little as 4 hours with us. And if they're well, they're traveled within 1 or 2 days to their sponsors. So there isn't the kind of screening that occurs with the Refugee Health Assessment Program, for example, which is nationally funded. I would say that our TB management has been a really incredible collaboration and kind of highlights the kind of collaboration that has to happen in these kinds of public health settings where, the academics get together with the NGOs and the public health, and on our public health department, for example, made available to us to have chest x-rays done for free in the public health department in a timely manner for our guests. So we put a travel hold on them if they symptom screen positive. I don't want to get into the weeds, but if anybody's particularly interested in the sort of development and the protocols of the kind of system that we run, I'd be happy to talk to them offline.
The next question is for Dr. Page. What the global north needs are safe and ordered migration processes. Could you talk about the role of academia in influencing the design of of such needed policies?
Thank you for that question. And I think probably what the person is asking is, of course, everyone wishes there was an orderly process for immigration and a path that didn't cause the disruptions that we're seeing, not only in this country, but in other countries in terms of, really tons of humanitarian suffering and human rights violations as people come up and then they're stuck at the border and family separations. And I think ideally, I think it was Dr. Hill who spoke about, for example, the labor demands that are in this country and the labor needs. And ideally, there would be really seamless and nimble pathways for people to come and work here, as one example. But we know that that's actually not been the case, and that's why we need immigration reform so badly. And so what I would say is, academia is an interesting question because how much can we influence? I think what we can do is provide evidence. And so whether it's the evidence and really highlight that in really rigorous ways. What's the evidence of what do immigrants bring to this country in terms of contributions, not only in terms of health, but other things. I know that I recently read an IMF report, and they were looking at, the Venezuelan migration crisis has happened throughout the continent, and most Venezuelan migrants have gone to Colombia and other countries. And they were evaluating, for example, the impact of integration policies like the ones that Colombia have taken up, which require an upfront investment, but the projections of the gains on GDP for these countries are much larger than the investment upfront, because of the things that we have talked about, the productivity of the people who are coming, but also generationally going in. And I would say, again, things like, I think when we speak about migration, there's often like black and white. It's either citizenship or nothing. And really, I don't think that's what we're talking about. First of all, let me clarify, migrants are very diverse. But if we talk about the most vulnerable migrants, whether it's economic migrants or people fleeing persecutions, some of them really cannot go back to their countries. But some migrants, especially economic migrants that are filling a lot of our jobs, would love to be able to go back and forth. And while they may not be perfect, worker permits are something that at least many of my patients would love to have, because they would at least be able to visit their families over the holidays. And I think the assumption that everyone that comes here to work wants to become a citizen and stay here forever is probably flawed. And we as academics can really start looking at that more closely. And I know Dr. Yang has something to contribute to this as well. So I'll shut up.
No, thanks, Dr. Page. That was really great. I just wanted to piggyback on this. What can academics do in regards to stigma and the evidence? Right. That's what one of the things that is our hallmark. What we really can contribute to the debate. I want to amend my answer, my prior answer. So to reduce stigma, there are really two approaches that work best, and one of them is actually education, obviously. So a lot of the information that was provided, for instance, during these different panelist talks would be tremendously useful in reducing stigma. That in tandem with sharing narratives, lived experience, illuminating, the facts that we that we disseminate to the public, those two things in combination actually have been shown to reduce stigma, at least for best reduce stigma for health conditions, and ought to provide a roadmap for how we can address stigma up towards migrants and immigration.
Thank you. We have next a question on how we rationalize how the negative impacts are on migrants, yet the studies showing healthy migrant effect. I know this is something that seems somewhat related to what Dr. Yang and Dr. Page presented on, but please, anyone feel free to weigh in.
I guess I can start, but I bet you there's others in this call that also have a ton of expertise and perhaps even more than me. So the healthy migrant effect, for those who maybe in the audience have not heard about it, is that when you look at the health outcomes, cardiovascular health outcomes and others, among migrants versus non-migrants of similar socioeconomic status, adjusting for that, you often see that migrants have better outcomes. I would say that that's sort of a very sort of overall gross generalization, and that certainly does happen in some instances. But the issues in the weeds, right? So first of all, it depends on what condition you're talking about. Migrants also, remember, are a sort of selected and biased group. And so, for example, if you're looking at migrants that come to the US through the southern border, who have had to walk thousands of miles to come here, that group is already selected for some type of health outcome because they're already healthier. There's also literature on the resilience. So we've been talking a lot about like so the downsides or the difficulties of being a migrant, but migrant communities have also very resilient networks, and so some of that may be protective. But then the last thing I'll say is that we don't see that effect in every single migrant group, and in fact, there's definitely differences by country, by different characteristics of migrants, et cetera, and that we also don't see that the same in every condition. So COVID, for example, is a perfect example of public health condition where there was certainly no healthy migrant effect, especially for those of the lowest socioeconomic status. So I'll stop there. There's probably other theories as well that migrants, as they get older, if they don't have access to healthcare, they go back to their country. So we're selectively not looking at that population. But I'll stop right there.
Do any other panelists want to weigh in? All right. I do want to move on to Stephanie Attinger de Cuba's question. In places that are less welcoming, what messages or arguments do you find are compelling to those who are / tend to be unsupportive of immigrants and migrants?
I'll happily say that. And among friends, since there are about 200 of us, it's money. And my co-panelists already spoke about this. Immigrants of a variety of statuses, entry without inspection, those who actually have TPS, labor visas, LPRs, USCs, the alphabet soup of migration. We pay into a system that we do not benefit from, and many of us pay into a system for many years and do not reap the benefits from it. And so I think selfishly, the reason why there may be a way to help combat that negative rhetoric is what's in it for me. Because if in fact the community starts to see the economic impact of entrepreneurship that happens at higher rates among immigrants who start businesses, as well as the tax contributions that they themselves will never benefit from, including Social Security, which then in turn extends the Social Security pool for the entire America of the US of us that they are not part of. The number of consumer spending that happens in local communities, SPLOS funds, as well as how that helps with infrastructure support that they may benefit from, but not necessarily reap in other ways, is significant. And so what we have found among the 7 standards that I shared with you with the welcoming standard, although safe communities is important because people are more likely to report crimes, especially like domestic violence or intimate partner violence. When you live in multiple households and exploitation that may take place, crimes, thievery when it comes to not being paid for a day's wage or labor that's taken place, like that helps create better communities that make us safe. Education, a better education at the K-12 level. And even if you start from birth to 5, that's going to end up redeeming benefits over the lifespan of a child into their adulthood and therefore minimizing public health consequences. But ultimately, I think the economic engine is one that affects and seems to like speak to people in a different way when money is tight and they know that there is a group of people who are contributing to this. Knowing that they are actively through an EITM number, for example, giving monies into this system, even though they know they won't benefit, as a way of showing legitimacy, trust, and a desire that if things should change with federal immigration policy, they'll have the receipts to prove that they've contributed to the America that they want to now be a part of.
Dr. Yang?
Thank you so much, Dr. Rodriguez. That's such a beautiful, message, and So if you remember the slide I put up around, migration stigma and that chain of concepts. So that chain of concepts also tells us how we can counter stigma. So if you remember, right, the first step is labeling, the second step is stereotyping. What Dr. Rodriguez described is really, beautifully really negates this core stereotype of being undeserving, right? Undeserving immigrant here, freeloading, these really regrettable and toxic sorts of stereotypes. And so if we can interrupt the stereotype at this second, sort of link, then that could potentially disrupt, stigma from occurring along all the different steps. So so thank you for that example. And I just wanted to tie it back to the overarching theory.
And actually, if I can piggyback on Dr. Yang, which is great. I know that one of the panelists talked about us not being monolithic, and that I would say is it's not monolithically being white, just that it is not monolithic to be Black. Like there is a diaspora of each of our identity groups, just as there is this hierarchy of immigration statuses and the various ways in which those political, economic, and social forces impact us and how we walk in this world, including colorism and accents and everything in between. But one thing I do see that is often not spoken about, and I think from a public health lens is really important, is high skilled immigrants. We tend to focus on this end because in the public health setting, you're probably working with the most marginalized and the most vulnerable. And hence there are significant and dire concerns for public health. But I also want us to just pivot even only briefly for those who are high-skilled immigrants, because if we could help change the narrative about migrants, that may be an easy place to start. And that would be being able to tell people about credential recognition, especially in the public health field, where there are foreign credentials and high-skilled immigrants who have levels of skills and knowledge that are often cleaning our homes, who are doing our lawns, when they actually could be the dentist, they could actually be the surgeon, they could actually be the psychiatrist who has linguistically, culturally competent skills that are not happening because we can't graduate people fast enough in a variety of health sector industries. The other thing is, I would propose immigration reforms when it comes to visa policies and expanding the H-1B visa program, therefore being able to allow for greater pathways for permanent residency, especially if you can attract and retain talent, have them be able to do some type of entrepreneurship or apprenticeship under someone else's license, knowing that they already have the revalida, they already have the validation in their home country, but to practice through a revalidation process here and tie that into the visa structure. And then ultimately professional networks. There's so many 501c4 organizations that exist, and yet there's a lack of mentorship. We tend to mentor those who are here, US born, going through our schools, which is fantastic. We want to graduate them and get them into the workforce, but there's very little that professional networks are doing to support those who are already here, who have that skill set, who are ready to enter into the labor market. And yet, because of language limitations or just not being able to get the appropriate sponsorship or even just a chance because there are no formal structures, really has made it a contentious environment for inclusive work environments and an incentive for people to benefit from the skills that people already have when they migrate here. So just want to speak out for that, knowing that my life has been touched by both extremes, and I see very little.
Well, we have about 5 minutes left as we finish wrapping up this incredible discussion. I do have a question just piggybacking off of Dr. Rodriguez's question, but to everyone. There are over 200 different types of visas, and you have everything from also immigration statuses as well. Everything from TPS to H-2B visas for people who are seasonal, to T visas for victims of a crime. And all of them sort of bring these different levels of healthcare access. What would you propose to a new administration, since we're really focusing on elections and that intersection with healthcare right now for immigrants? What would you propose in improving healthcare access for immigrants of different visa types?
Well, I'm not sure that there would be much interest in this, but I personally believe in universal healthcare as a human right, that many countries have signed in onto. So I don't know that there should be many distinctions. I mean, the only distinction I could see is maybe as a tourist, there could be some limitations in the type of care you can get, chronic care. But I have, as a tourist myself, been to countries where if something happened, I still got care. And so I'm not sure, you know, I know I'm talking about something that's probably not realistic in our current environment, but I really don't see why we should be making all these distinctions based on your visa status.
I agree with you completely, and I think that expanded Medicaid has allowed people to be seen irrespective of what they're called or their visa or their papers, and that it has so many positive implications from a public health point of view to keeping the workforce strong point of view. So I agree with you completely.
And if COVID didn't teach us anything in our modern history, is that if I'm sick, I'm more likely to get my neighbor sick. And so therefore, I'm more likely to get my neighborhood sick, more likely to get my city street sick, my county sick, my state sick. So even again, I'm using the very like, rather than like the metaphor of feed a bird with 2 scones versus, you know, kill a bird with a stone. There's an English axiom, no sé cómo se dice en inglés. But this idea of killing a bird with 2 stones or feeding a bird with 2 scones, if at the very least for self-interest, COVID-19 has taught us that as a public health priority, if we do not care for people because they're human, period, then we're going to end up all suffering the consequences. Much like we say about like a burning house. We all pay public taxes to be able to care for our homes. Just because the neighbor next to me is an immigrant and their house is burning, I'm going to be concerned that my house doesn't get some flames because my house is going to burn down too. The same thing's happening with Hurricane Helene and Hurricane Milton. When there's a national disaster, we don't ask people, show me your papers. Your papers are now washed away in the sea. You're a human being and you need to be cared for because you have human dignity as an inherent right because you breathe this earth and you're on this earth. So I would agree totally with Dr. Page and Dr. Hill and Dr. Yang as we're all nodding our heads. Civility is missing and civility starts with us. And so if we can at least treat our neighbors as we would want to be treated, I think things will be a lot better.
Okay, well, I see that we're almost out of time, so I'll wrap up our discussion. Thank you to everyone for joining us today and to our esteemed panelists. It was truly an honor to moderate this discussion and to be able to facilitate it. Thank you so much.
Oh, well, let me just jump in to say thank you to everybody. Before the panel, I was speaking to the panel and saying how much I was looking forward to this, how much I was looking forward to learning from you all. And not only have I learned from you all, but it exceeded my expectations in terms of how much I learned. So thank you to everybody. Thank you for being with us. Thank you for the work you're doing. And I want to thank the audience who has been, as always, quite engaged and for everything that the audience is doing around this issue, always, but particularly at this time. Everybody, thank you. Have a good afternoon and a good evening. Take good care.